Hello and good morning to all of you, or good day maybe at this point in time. I wish you welcome to the event that we have organized today from CHESS, the Health Policy Program of the EPC, the European Policy Center, which is kindly supported by an educational grant from Johnson & Johnson. My name is Hans Martens, as you can see, and I'm the chair of CHESS. So it's a pleasure to have the discussion today. And I think personally, I look very much forward to it because it touches on a lot of the, I think, very important issues for our health system these days. In particular, on the survival of the European model of health systems with, in principle at least, equal access to high quality healthcare for everybody. The pandemic
Hello,
has
good
made
morning.
its marks, as we know. It has at times overburdened the health systems. It has left also a lot of untreated or late treated diseases or other diseases, including cancer. It has left our economies in a terrible shape, not least the public budgets that we need so much for the health systems. If we add to that the other pressures that we have or strains on the health system, including the increasing pressure from demographics that suddenly starts kicking in now very heavily, I think it's obvious that we need to see how we can transform the health systems to make them more resilient. That resilient is the new black, if you like, the new word in health. But that means a lot of things for different people, but it includes at least meaning robust in relation to unexpected challenges. It means more sustainable, which means both economically and otherwise sustainable health systems, but not necessarily that we can pump more money into it because we might not have it, but to see how we can get more value out of our health systems through, for example, the transformation. Amongst the things that we will discuss today, I'm sure, is the issue of putting more effort into the early stages of the health system, the primary health care, the early diagnosis, getting more value out of the testing and the diagnosis that we do a lot these days, but also how to integrate, perhaps through digitalization or other ways, the health systems to be more coherent and at the same time more focused on creating value for the patients. But we also have a super excellent panel today to discuss these matters here. Let me begin with Jan de Maeseneer, who is a professor. He's also chair of the expert panel of effective ways of investing in health. They've just done, by the way, this autumn report about some of these issues here. Jan is also in Ghent, part of say a very integrated primary healthcare clinic, so works on it in practice every day as well. Francesca Colombo, welcome to you as well. You are the head of the health division at the OECD in Paris and has been with us in CHESS for many, many years. We have Tinne Vandensande, who is from Brussels, from the King Baudouin Foundation, where she works on a number of issues, but in particular, I think in this context, the Transnational Forum of Integrated Community Care, which you'll tell us a bit about the experiences that you have from there, or maybe a lot about it. That's another thing. We have Marianne Bernsteil, who is Senior Manager for Global Communication Impact for EMEA, Europe and the Middle East and Africa for Johnson & Johnson Foundation. And we have finally, who has joined us a little bit, I think, late at the start. I heard you came in, Loukianos, Gatzoulis, who is Policy Analyst in the Performance of National Health Systems in DG Health and Food Safety in the European Commission. This part of the Commission that has seen an explosion in the budget and the tasks, in the health policies for the coming years. And I think that is something that we can look into today. Also, because I think we should try to focus on ways that Europe can go, remembering the new status that, or rather how the EU can play a role in this, what we can do together at a European level, remembering the new health status that we have in the EU, a new budget as well, all the kind of new things that are coming up, but maybe also try to identify some good examples that can be replicated across Europe. So this was a very short introduction. I think we should now just mention that people, all of you in the audience, can ask questions to us, do it in writing, and we can try to raise them with the panel as when we heard the introductions. And I'll start with Jan today, if you are ready for that, Jan, because I know you have to leave us at 11 o'clock. So if there are any questions to you from various sides, please make certain that this is done within the next hour or so. So let's have some short introductions from all the panelists, and Jan, you have the floor.
Thank you very much for this invitation, and I will go through some slides on the topic making European health systems more resilient through strengthening community-oriented primary health care. Next slide, and as already told, the background I speak from is from the work with the expert panel on effective ways of investing in health. We are 17 people with an academic background. We are independent and we produce opinions where we integrate evidence with our views on the future of healthcare in Europe. And one of those I will present now. Because, next slide, please, we have challenges that are common to all our member states. The first is accessibility. We saw it in the COVID pandemic. Social inequalities. We know that people from ethnic cultural minorities and people living in poverty have been hit much more by the pandemic than other people. We have an aging population, and that was also a factor of vulnerability, and multimorbidity becomes very clear a risk factor when it comes to the outcome of COVID-19 impact. Of course, we have challenges in technological development and opportunities. There's a financial pressure on the health systems and the sustainability and localization. That means we see the global problems in our daily practice are two important challenges as well. And of course, COVID-19 has really challenged the resilience of our health systems. Next slide, please. And therefore, we wrote up an opinion on the organization of resilient health and social care following the pandemic. And we used the definition by the Health Systems Performance Assessment Group, namely that resilience is the capacity of a health system to proactively foresee, absorb, and adapt to shocks and structural changes, and both are important, in a way that allows it to sustain required operations, resume optimal performance as quickly as possible, and transform its structure and functions to strengthen the system and possibly reduce its vulnerability to similar shocks and structural changes in the future. And of course, COVID-19 has raised questions on improved preparedness, on how to strengthen primary care, on how to reinforce the resilience of hospitals, looking for solutions that also involve long-term structural challenges in public health structures. And one of the things we came up with, next slide please, is that we have to build a kind of tool to assess the resilience of our health system, looking at the building blocks of health workforce. The role of community care is very important, the availability and the innovation of medicines, the appropriateness of infrastructure, the appropriateness of information systems, very challenging, the governance of our health system, the financing, the way health services are developed and are scaled up, and finally, the health promotion. And we try to find that these are important indicators that we should score in a quantitative, but also in a qualitative way when we look at the resilience of our health systems. And so we finally came up, next slide please, with a kind of suggestion how you can build up a resilience test. And that could be feasible in Europe. We have prepared that, and this requires now implementation. And we think that these 5 phases that are absolutely needed to build this resilience test could be picked up by the European Union by investing in the development and implementation of this testing of health systems, and create a kind of learning community in regions and member states so that we can continuously improve the resilience of our health systems. That was one of the conclusions. Next challenge that we are faced with is, of course, the healthcare workforce. All countries are struggling with appropriate indicators for needs assessment. What is the profile of the workforce you need, in what numbers, and operating in what context? And so the forecasting and planning becomes a real challenge. Also, when you have unforeseen events like pandemics that all of a sudden show up. And the issue of recruitment and retention becomes a very important one. And I think that as European Union, we should really try to recruit our healthcare workers in the member states. And we should really see that we avoid to contribute to intercontinental brain drain, which is really an issue. And I think that Africa, Asia, Latin America absolutely need their healthcare staff that they have trained. So we should look what we can do in our own countries at that level. Another important challenge is that we have become over-specialized. Strengthening the generalist component in profiles of healthcare workers from an eco-bio-psychosocial model is very important. So we need people with a generalist broad scope. And of course, those people don't have to work in isolation. Teamwork and task shifting is important. And we just produced 2 years ago this important opinion on task shifting and health system design, where we address this issue thoroughly. And of course, in all this, it comes out of the studies also by OECD that primary healthcare has an important role to play, because it integrates the orientation towards individuals, providing reactive care, and in the meantime, it also looks at population and providing proactive interventions. And the way we can do that is by integrating primary care and public health in what we call a community-oriented primary care approach. And next slide, please. It has been stated very clear that community-oriented primary care is really the healthcare model for the 21st century. And it has been defined as the systematic assessment of health needs in a population, the identification of community health and well-being problems, the implementation of systematic interventions involving target population, and monitoring the effect of changes to ensure that health systems and health services are improved and congruent with the community needs. The interprofessional team, consisting of primary care workers and community members, assesses the resources and develops strategic plans to deal with problems that have been identified. Community-oriented primary care integrates individual and population-based care, blending clinical skills of practitioners with epidemiology, preventive medicine, health promotion and empowerment, minimizing the separation between public health and individual health care. And I think that that is one of the most important lessons from our experience. We have to integrate that, and we have continuously to identify the health problems in the community, to make a community diagnosis, develop interventions, and monitor the impact. And I think that that kind of cycles at all levels of the healthcare system becomes more and more important. Next slide. How can the EU improve cooperation between member states and invest in transitions of health systems? Well, first of all, I think that support of planning for improved preparedness is extremely important. Neighboring countries, neighboring regions should plan together their capacity and availability of, for instance, intensive care unit beds. Also looking together at resources, facilities, equipment, and supplies in order to be more prepared when a pandemic arrives. Secondly, there should be an increase of the research capacity through integrated interdisciplinary data systems. UK gave this example of the recovery trial that they could do already from the very beginning of the pandemic and see that dexamethasone had an impact on the development of the disease. Well, why could we not prepare our European clinical health systems and health platforms, health data platforms, to prepare European clinical trials on the spot when we have new challenges that arise? And thirdly, strengthening solidarity and equity is extremely important. For instance, an equitable vaccine allocation, I think, is for the EU important, for the member states, but also beyond EU borders, because we all know that if Africa and Asia will not be have been vaccinated appropriately, Europe will not be safe. Next slide, please. And finally, probably the most important challenge that we learned is that we have to look critically at the way we are constructing our health systems. And we do it based on a basis, which is a public health, the prevention and screening. Then the next layer is primary care. The following layer is secondary care. And then on the top, you have tertiary care. I think, and others do think also, that we should turn the pyramid upside down. We should start from the population at the top, invest in health literacy and empowerment. We should integrate social care, public health and primary care, so that prevention, health promotion, cure and care, and rehabilitation and palliative approaches are integrated at population level at the community. Only when needed, this level should be supported by secondary care with precise interventions that are needed in certain episodes of people's life. And finally, there's the tertiary care that should help for those people with very rare conditions and that need special expertise that we concentrate in Europe in a beautiful way, I think, in the European reference networks. And I think when you look at that, then I see that many countries are struggling with this transition. How can you go from the past to the future? Because at that moment, you have to pay twice. You have to pay your actual system that's still very much hospital-based. At the same time, you have to strengthen your population-oriented primary care system. And paying twice is a very difficult thing for politicians. Therefore, I was wondering, could EU not invest in the transition costs of health systems when they switch from hospital center towards primary healthcare based and community oriented systems? I think that could be a good way of spending a part of the money that will now be available. And I'm absolutely sure that Loukianos will tell us more about these possibilities. So that was my final message. I thank you for your attention, and I'm open to questions. Thank you.
Thank you very much, Jan. I think there's quite a lot of questions here. I mean, you know that personally I agree with all the conclusions that you did here, but I've also seen how difficult it is to do transformation. There's a lot of conservatism in populations. How fast do they want to go? There is, of course, amongst the politicians, but there's also, I have to say, in the health professional circles as such. And moving towards, let's say, from sick care to healthcare is probably what you were trying to say here, is absolutely a good way to go. Not necessarily, I think, to cut down on hospitals, because we'll probably need them, you know, with the aging population and so on and so forth, but actually to try to prevent more diseases, to come to ease the burdens and so on and so forth. It will be very interesting to hear comments to this from the rest of the panel, from the audience as well. And I think for a very long time to come, a lot of thought here, a lot of good ideas and so on and so forth. So let's move on directly and give Loukianos a little bit of time to reflect on an answer here, how easy it would be to move the member states into this transformation and to learn practice from each other, which has surprisingly seems to be a difficult thing to do as well, because everybody have the world's best health systems, I suppose. So why should we be able to learn from others? Although it's a very free ticket, you know, to make improvement. But let's talk about that along the way. Francesca, you have been doing a lot of studies on also combining the health systems with the economy during the pandemic here. What are your comments to the transformation situation?
Well, thank you very much, and thank you, Jan, for you know, putting so nicely the question. It's a very nice way to really kick off the conversations. I will make some general remarks, but focusing specific on the issues of primary care, community care, you know, that first layers of care and the importance of it, and how they have responded to the pandemics, but also how we need to strengthen primary health care from the future. And the reason why I focus very much on that, because obviously right now we focus all the attentions about the issues of resilience of health systems, as Jan has rightly alluded to. I mean, the crisis has been a shock and an alarm bell in many cases. That our health systems that we thought were strong, we thought we had among the best in the world, and we just realized that our own health systems in the most advanced economies are just not strong enough. And that clearly triggers the whole reflections about how that strength can be improved, and how perhaps we need to rethink the models that we had in the past. Now, that comes obviously to issues that have been and we've been pushing on for many, many years, but clearly where we have failed. The first clear pillar of a resilient health system, which somehow builds the foundations, is the investments in public health and in primary healthcare. I mean, here we're talking not in itself about the resilience of health systems, but really the resilience of populations. And if we see in the case of COVID-19, the shock has been huge, but the consequences of it have been felt unequally across different socioeconomic groups, and also across those who are more vulnerable than others. And the clear element of vulnerabilities has to do with issues related to chronic risk conditions, but also underlying things such as poverty, low education, unhealthy behaviors, and so forth. So I think the very first message that we come out from this crisis in terms of resiliency is that we must invest and build the resiliency of populations. And that requires a very strong focus and efforts on public health, on addressing the social determinants of ill health, on addressing drivers of inequalities, socioeconomic inequalities, and linking that to the health system. And in the health system, the very first point of contact, of course, is the primary care sector, the community care sector. I'd like Jan, when you say talking about a community-oriented primary health care, absolutely fundamentally is really this intersection between the public health and primary health care as a first point of contact. And the context of this current crisis, we have seen so evidently how primary health care has a fundamental role to play, in two big many ways. One is obviously to really support the broader health system by minimizing complications of people who have directly been affected by COVID-19, facilitate the quick referral to make sure that people, who are affected directly by COVID minimize their risk of complications, but also providing all that support from the community, the informations that you need, the engagement and management of patients who might be experiencing some symptoms and so forth. I mean, all of that, we have seen it in some countries, not necessarily in all the countries, about primary care really taking this role of providing a strong COVID-19 community care services and approach. That's it's a clear thing, but there is obviously the other fundamental point about how primary health care has a fundamental role to help that strengthen that resilience of populations, which I mentioned too. So really the issues of the ongoing care for patients who do not have COVID-19, but who might have other conditions, and addressing those risk factors for them. What we have seen, it's quite clearly that during the crisis, those services have been very much disrupted. I mean, in the first wave in particular, the reduction in services, the foregoing of care by people who have chronic conditions, or even who have cancers, for example, or who have foregone detections of cancers. The even urgent referrals from primary care have been disrupted in many ways. People were just afraid of going and see a doctor. And I think there is a clear role to play in reassuring the populations, but in also setting up different, services, different way, a more modernized primary healthcare. And that's linked back to things that we've looked very much before the crisis, how primary and community healthcare plays that fundamental role, but at the same time needs to be strengthening itself in terms of the information infrastructure, for example. And Jan alluded to what extent we do have the right information available in primary healthcare, and how that links across the health system with specialized care services, with mental health services and support. That's really clear element for further strengthening and investment of primary health care. But if you think also the issues of skills, do health professionals have the right skill to manage complex care needs, maybe even the confluence of chronic conditions and risk from infectious diseases? Do they have the skills to manage that dialogue and communication with the populations? And at the same time, do we use the skills of health professionals rightly? There are other professions rather than the medical doctor. Pharmacists have been very much used during these pandemics in a way that we had not seen before, and that creates opportunities for thinking about the skill mix and the roles in primary care differently. But the third area is that can definitely, where primary care can be strengthened. We have seen, and there's been a huge acceleration during the crisis, of course, is the use of more telemedicine, more digital tools. Jan, you mentioned about the fundamental issues of health literacy, and I think health literacy is not just health literacy, but it's also the digital literacy of populations in an increasingly digitalized health system. But the opportunities are there, and they're very, very much wide. There has been an exponential adoption of things like telehealth, telemedicine, institutional barriers, reimbursements, barriers that existed have been taken away. But at the same time, we now move towards a model which a much more digitalized, health services and health information as well. Well, we need to equip populations, and we need to equip health system as well to manage that consultations remotely as well. I think that's something that we need to reflect upon, how in the future we can strengthen even further that new, more modern approach of primary healthcare. And I think there is definitely a need to look at the innovations as well. I mean, I mentioned the innovations in tasks and responsibility, community pharmacies, their role. We've seen in a number of countries that have really been leveraged during the pandemic. But how about more home-based program? I mean, we have the idea of healthcare with people going to healthcare facilities, people going to health systems. But quite clearly, there is an issue of reconsidering how we can have services going to people, and home care programs is also another areas that deserve consideration. I will stop here for the moment. I'm sure that there will be more into the discussion, but definitely I think a big shock that we have all seen, a huge need to reflect about the weaknesses and what we did wrong in the past, but opportunities as well to just have much more resilience, community and primary care focused systems.
Thank you very much indeed, Francesca. As I hear it, you are pointing to a number of issues. One of them is trying to do as much out of hospital as possible. First of all, investing more, and we are actually not investing a lot in the primary healthcare and in health promotion. I've seen the figures from OECD, they're shockingly low. But of course, hospitals are very, very expensive. They're also useful, as we all know. But out of hospital could also be at home, as you were saying, both the long-term care for elderly, but also I think recuperation from hospitals and so on. One of the things you can try to do is look into the health at a glance and try to see the hospitalization periods, how much it varies from country to country, and link that into, well, can that work with home care as well? There's a couple of things that I think we might want to discuss as well, because you're talking about when we should focus on a more resilient population, besides the health systems, also to issues of lifestyle and so on and so forth. Is there a bias here in who we actually can address and catch up in the system? And I think maybe Tinne and Jan can help us a bit answer on these questions. Is there a social bias in this? Are we going to lose some people on the ground? Are we also creating a new inequality if we digitalize more? So nothing is without problems, but a lot of good thinking here, and we should focus on resilience, not only on hospitals or the health systems, but also on the population. So thank you very much for that. Tinne, you work on a number of things in the big foundation, including, of course, this question of community healthcare. So maybe you can answer some of these questions already, but we're very excited to hear what you have to say. So over to you, Tinne.
With pleasure.
Yeah. Nice slides.
Yes. The concept of integrated community care has been launched in 2018 by the Transform Partnership, which is a collaborative of philanthropic organizations from across Europe and Canada. And in the meantime, it has become, it is an international learning coalition aiming to foster integrated community care for all. Transform, the initiative of Transform, is conceived as a learning journey. It's learning by doing and doing by learning. Let me start with some key takeaways. What is required is a fundamental shift in the way we value and understand the role of communities as an integral part of the system. Community care is as important as intensive care in hospitals. And yes, we do recognize community participation as crucial during the pandemic, but it must remain a priority in a post-COVID world, as it is an important shaper of community resilience. And ICC builds upon the World Health Organization vision for primary care. But ICC will certainly benefit from a new type of health and welfare provider. And it will also benefit from a more structural and empowering financial logic. Let's now dive into what, how, and why integrated community care. ICC acknowledged that communities are essential partners. They contribute with invaluable assets, relationships, contextual knowledge, entrepreneurship, public spaces and services, and locally supportive ecosystems. And ICC envisions a paradigm shift. The key difference is that the move away or the move beyond delivery towards genuine co-development with individuals and communities that are mostly framed as recipients. And ICC empathically addresses the broad determinants of health through evidence-informed policies and actions across all sectors. ICC pivots on greater integration between primary care, public health functions, social work, and neighborhood development within a given territory. And place-based governance is a crucial competence. And although ICC is about local experimentation, which is fine, it must be embedded in a continuous process of whole system innovation. And all this together gives us a root definition of what integrated community care should be. It is about co-developing health, care, and social support infrastructures and services with the aim to enhance the quality of life, social cohesion, and resilience of a local community. To guide action within this complex transition, the ICC Learning Coalition has developed a set of 7 effectiveness principles. Working with effectiveness principles is rooted in developmental and principles-focused evaluation, which is a methodology developed in Canada to evaluate differently when it comes to innovation. And what you see here is a set of 7 effectiveness principles that we clustered in 3 sections. The first section is about authentic partnerships to co-develop health and well-being and to enable participation. The second on building resilient communities, and the third is on the dynamics of evaluation. Within the frame of this session, I will pick out one of the principles of the first section to strengthen community-oriented primary care that stimulates people's capabilities to maintain health or to live in the community with complex chronic conditions, and take people's life goals as the starting point to define desired outcomes of care and support. The way each principle is phrased is very, very important in working with effectiveness principles. These principles follow the guide criteria. They are developed by Michael Quinn Patton, and the guide criteria, they say a principle must be guiding, it must be useful, it must be inspiring, it must be developmental and context sensitive, and it must be evaluable. And this set is really the strategy, the core of the strategy of integrated community care. Oh, I went back. So a few words on the typology of ICC. The constituent elements at the center of this visual are the instigators or the drivers, the centers of gravity. That means that practices can be developed from a perspective of primary care, or they can be developed from a community building perspective, or from a spatial environmental perspective to improve the quality of life. But most of the practices will be hybrid because they combine at least 2 perspectives. I listed a number of emblematic exemplars of ICC on the slide to give you an idea, to give you a flavor of the variety on the field. Community health centers are well known. They have a long history, but they are still evolving. While community mental health centers, caring communities, or compassionate communities are gaining momentum. There are many challenges for the implementation of integrated community care. In our strategy paper, we listed 5 of them, key obstacles or key challenges. I will pick out 2 of them during this session. First is the challenge of meeting halfway. What we see is we see a lot of bottom-up local initiatives, citizens-driven, but we also see a lot of top-down initiatives that are initiated by primary care professionals, by local authorities, or by other professional drivers, which is fine. Both movements are valuable, but it's about finding the right balance between both trajectories in order to align them towards a shared goal. And then the need to train a new type of health and care providers. I think also Jan spoke about it. It's really about a new profile that is more motivating, more facilitating, and that is more familiar with working in interdisciplinary teams. And accounting for context when addressing ecological, social, or economic determinants. So what future for integrated community care? In order to make sure that ICC becomes the new norm of care. Well, this discussion is quite complex as it unfolds against the background of uncertainty. We don't know how a post-COVID future will look like. And therefore, the ICC community has developed a set of future scenarios. Each of the 4 scenarios present a plausible future, and altogether they give us a feeling for the future possibility space associated to the presence and aftermath of the coronavirus. And these 4 scenarios, this scenario thinking exercise has helped the Transform Partnership a lot in developing, in reflecting, discussing on a pandemic robust strategic agenda for ICC for the next years. Thank you. So I can come back on these scenarios if you want, so Hans, during the discussion.
Okay, thank you very much. I think here we are going a little bit further in the integration, and I think that's very useful to think about integrating with the social context as well. I suppose this is also a good way of identifying some of the lifestyle-oriented questions about resilient parts of the population and so on. So I think what would like to look at, if we have time to discuss, Tinne, is also some good practical examples. I know one, and that's the one that Jan worked with, and there's an additional issue there in Ghent, because I think you're dealing with, I don't know how many nationalities and how many languages, but there's also this question of cultural differences in the approach and so on. So thank you very much for putting this up. I noticed also, Tinne, that you had a point about giving some of the financial incentives to make this happen, because there's a question here about who pays for what and how do you integrate that. But let's see what we can come back to. I think time is running very fast, so Marianne, I'll move over to you. When we had a little talk before this, you were talking about one issue, which is, can we get the populations on board? How quickly do we want this transformation to happen? I don't know if you want to address that, but it is obviously a very important question as well. But over to you, Marianne.
Yeah, thank you. Thank you for this inspiring conversation. It's really great to see all of the speakers addressing that very important topic. So I represent today the Johnson & Johnson Foundation, and specifically the work that we're doing around global community impact. we've been involved with supporting and championing people on the front line. And I like to describe our strategy as an onion. What you see outside into the world is really support and capacity building of the health workforce. But when you peel the onion, what you see indeed is the desire to better connect community care and community health and primary care. And then when you peel the onion once more, ultimately it is our aspiration and intention to support health systems that privilege prevention, positive health, resilience. In other words, health systems that are designed to sustain good health as opposed to curing bad health. Health systems that are designed to reach out to people proactively as opposed to respond to disease reactively. And I guess also health systems that are designed to have citizens' pathway into health and well-being as opposed to patients' pathway into cure. And from today's conversation, I think that alignment across the speakers, that would be our common aspiration and vision for the future. There is indeed a question as to how quickly we can get there and how radical the transformation is needed to get there. I like to use a metaphor that is used in the book called The Upstream Doctor, of two doctors at the bottom of a waterfall trying to save children from drowning. And they'll pull the children out of at the bottom of the waterfall until one of them says, "Let me go up the waterfall and see why they're falling." I think there is something about community health that is about intercepting those who can be intercepted. And in our view, we've been working on community health in the Global South with governments designing community health strategy to achieve universal health coverage. And in the past 2 years, we've been trying to get community health more resonance across Europe with more or less successes and starting funding the community health space. But we can see in our view, we see the response as a three-layered response. And I think we heard that today. It needs to happen at the individual level. And obviously health literacy and digital health are key enablers to help individuals to own and manage their own health. But there is a risk both to dump the responsibility on people and increase inequalities. And there is also a risk in terms of losing human-centered intervention. So in our view, we see community health as really bridging that individual level, individuals owning and managing their own health to the best of their capabilities and literacy. And that integration that happens through community health, still intercepting and being in that positive health space, and yet that integration with primary care and facility-based care. It brings that human-centered design and that holistic aspect of health. But obviously there's still a lot, it's an emergent field, and there is a lot to understand how those community health come about and what are the promising community health models and those new models of care that are promising for the future. There seems to be a need to surface more pioneering practices and pioneering models. I know Transform has done some work around the effectiveness principle, which is so important in understanding how do you design community health that works? What makes it work in an urban setting versus a rural setting? Who community health workers are, I think from my understanding across Europe, from pharmacists to community nurse to community mental health navigators, they take different shapes and form, and they also deliver different interventions. They are trained differently. The curriculum is not always clear or set. And where do they operate is a big question. I know Tinne and some of you, mentioned the house, the home, the community, a kind of place-based approach. The where is as elusive and diverse as is the who and how they're trained and what do they deliver. So in our view, although especially now through COVID-19, and some of you mentioned the increased roles of pharmacists. Being French, I've seen and heard now pharmacists vaccinating across France. I think that task shifting had to happen by default. But how do we keep that momentum? And almost from the fragmentation that is currently happening, how do we learn what is working and how can we capitalize and have a more harmonious way and approach for the future? And there is a big elephant in the room, which some of you have alluded to, but how do we move towards economic models that are incentivizing health and well-being? It's probably the biggest challenge in front of us. So as a foundation, I think our commitment is contribute to the learning journey, to better articulate a common aspiration and a bold and long-term aspiration for transformation. How do we make that shift to shift from that kind of disease-centered to resilient-centered health systems? What needs to happen, and how can we be catalytic in understanding the best practices, pioneering practices? What's the importance of foundation like ours to generate evidence and to support that evidence generation? We're working with Mental Health UK, for instance, on a community mental health model. We've been involved with them for the past 3 years in designing a community mental health navigators model. Those are individuals that come into the home and look at a resilience model of severe mental health patients. The importance for us is obviously to invest in the model, to scale it across the 4 nations, but also to generate robust evidence. How does that improve health outcomes? And also, how does that alleviate some of the burden on the health system? So we have a third-party organization that works on all the impact measurement, so that in the hope that in a couple of years we can turn to the government with that evidence in hand. There's obviously a lot of research that's still needed on the return on investment of some of the community health models. And although in sub-Saharan Africa, $1 invested has a return on investment of $10, in the US, recent studies showed $1 invested, $2.50 is saved. I haven't yet seen any of those figures in and across Europe or on any member states. So I would be happy to be shown wrong and to see that data if any of you knows about it. But at the end of the day, as a lot of you have said, it all starts with people. And Hans, you were just saying, how radical do we need to be? Well, my question is, who are those health systems leaders that are like-minded and that are ready to challenge the status quo? And what do they need to be better equipped to rethink the system? We're working with the School for Systems Change on a base camp for health systems transformation. And we are trying to build an open innovation community that looks to propose tools and methodology to help systems leaders to rethink the system. And this is only capacity building. How do you rethink your system? How can you shift from cure to resilience? So that's a start, but I think there is obviously a lot more that needs to be done. So I'll finish by saying, how can we be bold and come together with a joint vision? Because all of the panelists are doing the most amazing work. Is there a point in case to come together so that the vision can't be overlooked? And what's the level of maturity and our aspiration? Is it in 10 years? Is it in 30? Or is it in less? And then finally, if not us, who? And if not now, when?
Thank you, Marianne, but it has to be now. It has to be soon. We have to come together. Just a couple of things you were saying, that in Africa, in America, so and so many dollars come out of the investment. We don't have figures for Europe. That's because we use the euro, not the dollar. Okay, that was a very bad joke. But what I really wanted to say is that maybe we should think a little bit in value creation and not just dollar creation, if you understand what I'm saying, not just for the patient, but also for the health system and for the society as such, because you are very importantly talking about economic models that works. We have been trying to have payment and reimbursement system based on value, but they are also not finished yet, because how do you want to distribute across the line? And now, as Tinne was saying, we also need to integrate the social services and measure their contribution. So I think there's enough to be done. Let's move on it as fast as possible and not wait 10 years. Marion, was my answer. Now, I wanted to go to Loukianos because we need to know what the EU is actually going to do about this. But just before, I know that in 10 minutes, Jan is leaving us. We've had so much information that the time has progressed a little bit more than I expected. So Simona, can I ask you, do we have any questions that directly are addressed to Jan at this point?
Thank you, Hans. We do not have questions for the moment. I think our audience is still waiting to come up with questions.
I just wanted to make certain because I think in a few minutes Jan is going, but there will be, I hope, other opportunities to discuss further on with Jan on this. So with these few words, Loukianos, you are now sitting on the top of the money pile of the new budget for EU for Health, and there's a number of things going on, cancer plan, EU for Health, HERA, and I don't know what. Are you going to address some of these issues better in the future? And can you also maybe, or we can discuss that later, but can you also say a little bit about how the member states actually look into this idea of sharing information and adapting the best practices, etc.? Jan, it's over to you.
Yes, certainly. Thank you, Hans. I can try to give you some information about all these things. We heard a lot about what do we need to consider to strengthen health systems from our previous panel members. I don't really want to repeat any of this. For me, there is one overarching action that we need to keep in mind, and this is we need to provide the means and the resources to health systems to become stronger, more resilient, more accessible, and more effective. And there are two keywords that I actually like to put on the table about this. Invest and reform. These are the two key issues. Invest in more facilities, in more staff, in more supplies, change the care model, do the resilience tests, make sure we have a sufficient and skilled workforce in place, strengthen primary care, integrate care, make better use of digital tools, IT systems, telemedicine, and so on. All these things are options, actions, avenues of consideration. And all these really have to do with the transformation of health systems. Now, the Commission can certainly support member states in this endeavor, those who want to move forward, and we can certainly support them on both fronts, on the investment and on the reform side. We can help member states build the know-how and capacity they may lack if they want to reform health systems and implement new care models, and we can help them mobilize investments for large-scale transformation, going beyond pilots as well. And these two are important because if one is missing, not much can be achieved really. You have seen at the end of last year the European Health Union package, and part of the actions that are listed there really have to do with this support to member states to help them strengthen the health systems, to initiate and implement health system reforms, to overcome long-standing structural weaknesses. And the actions revolve around strengthening cooperation, making more effective knowledge brokering and exchange of best practices, and even offering technical support on the ground for building people's know-how and capacity, as well as the financing from the programs. All these can certainly be done with a range of tools and programs that have been made available in this new multi-annual financial framework. It is, for instance, EU for Health. It is the Horizon Europe program. It is the Digital Europe program, the Recovery and Resilience Facility, the InvestEU program, and the structural funds, cohesion policy funds. I can start giving some examples here because just throwing the names doesn't mean much. We can certainly think how much more we could do in the domain of transferring good practices. Some of this is already happening. We have launched projects under the current health program, for instance, to transfer good practices in the domain of integrated care. A joint action kicked off last October, where 14 member states are working together with the initiators and the owners of 4 good practices in integrated care, from the region of southern Denmark, from the Kinzigtal area in Germany, from Catalonia and the Basque Country in Spain. And the member states are looking at which elements from these practices are they most interested in, what can they consider transferring and adapting to their local setting, and they will get the support and the help from the owners of the practices to try to get it right. We also have other twinning projects which are currently running in the health program. They bring together in one consortium the early adopters of practices in integrated care with the next wave of adopters in Europe who are interested to learn from them and embark on the difficult task of implementing integrated care, for instance. Other examples, we have packaged a lot of resources and knowledge online. We have a best practice portal in Santé, how to prevent and manage non-communicable diseases, for instance. On the EU health policy platform, we have put a resource center, as we call it, for integrated care. It has inside case studies, guidance how to implement integrated care, good practices, and even tools. For instance, one of the tools is the maturity model, which has been developed by Health Program Project, Sirocco. And this is a tool that health authorities can use to make a self-assessment how ready they are in order to implement integrated care. In which areas do they actually need to improve because they have certain weaknesses? And this model also, this tool can be used to indicate the specific requirements that a good practice has in certain domains, and therefore a health authority can look at their own self-assessment, they can look at the requirements of the best practice and realize, am I in a position to take this over, to transfer it? Or do I have certain gaps where I really need to improve? And then you can imagine what can happen. They can contact the owners of a practice to try to get some advice and support how to do it. We also have a dedicated program that offers technical support. In the previous programming period, it was called the Structural Reform Support Program. Now, in the new programming period, in the new MFF, it is called the Technical Support Instrument. But what this does is it offers technical support, expert knowledge and support to health authorities to design and prepare their health reforms in various aspects. And as we talk today about primary care and integrated care, for instance, there are examples that this is already happening. This program has supported Austria, for instance, to reform the primary care sector and to establish primary care centers throughout the country. It is also helping Belgium and Flanders in particular with the implementation of their reform in integrated primary care. It is helping Estonia, the ministry in Estonia, to develop a strategy towards integrated care, how to develop models for specific target groups, and how to also work out incentive models. We heard about that already, how to work out incentive models for integrated care. So this is another very important and very practical instrument that is available to the authorities of the member states. We can talk about financing as well. Some of these programs that I mentioned before emphasize on the collaboration between member states in exploring new solutions, in piloting them and testing them. For instance, the EU4Health program and the Horizon Europe. Other programs focus in providing larger amounts of money to effect the real implementation on the ground. And this is, for instance, the new Recovery and Resilience Facility, which is a new program in the current programming period that can offer grants and loans to the member states to finance reforms and investments to mitigate the effects of COVID-19 come out of the crisis, and investments in health are, of course, eligible. So member states are preparing the recovery and resilience plans. And it is at their discretion if they actually want to affect this transition of the care model that we will be talking about today, from hospital to primary care, etc. It is a possibility. Another possibility is offered by the cohesion policy funds to do these things. Let me give you an example from the previous programming period. We launched a study in Sunday to see what was happening on the ground, how member states were using the financing from the cohesion policy funds. And at somewhere in the midpoint of the programming period, we discovered that about 1.6 billion euros were utilized by member states. About 16 member states were doing this in order to reform health systems, to do reform projects. It could be about perhaps the reform of their mental health sector, or really moving out of hospital and strengthening primary care, or integrating health and social care. It is a significant tool again. Member states are aware of it. They have already started using it, and they can consider using it even more. And we also have the InvestEU program, which offers loans and equity financing to project promoters, primarily through the European investment banks, but also national promotional banks, to affect large-scale projects as well. It can be in health infrastructure, in services, in digital transformation of health. All these are possibilities. So there are a lot of things happening. And the last thing I would like to mention, perhaps just to wrap up, is we may have also a European partnership on the transformation of health and care systems financed under Horizon Europe. It is a possibility. Member states are working on it. They have developed a strategic document which is publicly available, and it will be about doing implementation research, exploring the care models, how to adopt them, how to transfer them, how to guide this process, do pilot projects, twinnings, capacity building to succeed in implementation. I think I have given you a flavor of what can be done with the support of the EU programs and actions, and I'm happy to take any other questions. Thank you.
I needed just to unmute, but thank you very much indeed, Loukianos. A lot of new things are happening, and I think it's still developing. As you were saying, there are things in the air that we don't know about yet. In addition to that, let me also just ask, as far as I know, you are continuing the health at a glance process together with the OECD, and we can expect some country studies by the end of this year that might also take some of these issues up into account. Is that correctly understood?
Yes, we're continuing this, and you know very well, every 2 years we publish a set of country health profiles. So in the year 2021, yes, a new range of country health profiles will come forward, and this is work in progress.
Thank you very much. I knew that, but I just wanted you to say. So we'll also look forward to maybe present them and have a discussion about them. So thank you very much for these interesting, how can I say, inputs to a very, very important discussion. Jan, I see you haven't left us yet, so let's just have a look at the questions coming in here. Simona, can you help me a bit if there's anybody specifically to Jan, or otherwise?
Thank you, Hans. There are a couple of questions, but I cannot see some questions specifically related to Jan. Keeping in mind that he has to leave, I would like to thank him, and I would like to mention to the audience that if they have questions specifically related to what Jan said, just send them over to me, and I will try my best to coordinate with Jan.
Thank you, and thank you very much for participating today, Jan. There was also a question that I can answer, and that was whether participants can get the slides that we have seen today. I think from Jan and from Tinne, and I think the answer is yes, you can. And how do you do that, Simona? By writing a mail to you, or do we send it to everybody?
Just reach out to me and my colleagues, and we will share the slides.
Good. Can I ask, maybe just before we go to the individual questions coming out, there are people here who ask about really good practical examples. Tinne, in the approach you have and in the project you have, maybe I was not attentive enough, but did you mention the number of countries that you work in, and are there any particular cases that you would like to highlight, or country or region or cities?
We're working in 6 countries in Europe, and we're working together with Canada, with 2 philanthropic foundations over there. But on the website of Transform, and it's mentioned on the last slide of my presentation, is the link towards the website where you can find numerous practices that are analyzed by experts and are introduced by communities themselves. So I could maybe give one example that is, I think, quite crucial also during COVID pandemic, is we see the need and also the rise of low threshold mental health centers for youngsters. And what is there so typical to say that you can speak about integrated community care is that those centers, you know, maybe some of them, the headspaces in Australia, but also in Europe, in Belgium, for instance, and the foundry centers in Canada, that they are managed not only by mental health professionals, but also by experts by experience. So, and they are really part of the community. You can't go in there without even having a question. You're welcome. And you can talk to other experts by experience, or even without any mental health problem, you are welcome. So it is low threshold mental health care within primary care. We know at the moment that in primary care, the mental health focus is really quite low, and we should really work on that mental health care is available for all.
Right, thank you very much. One question that I would like to ask around the panel here, maybe first of all to Francesca from the OECD, is the question of more and less. If we want to put in the emphasis on making systems more resilient and the population, as you were saying, the easy thing would be to say, yeah, but we keep the investments that we have in the other parts of the sectors, in the hospitals and in the care sectors and so on, and then we just add a lot of money to the primary health care sector or to the health promotion and so on. In my introduction, I basically said, I don't think we will have the money just to add to it. What are we going to have less of if we're going to have more on the first part of the health system, the primary part? Anybody could answer, but Francesca, to you first.
Yeah, and maybe you're right. I mean, we're gonna be facing with significant fiscal pressure. Although right now, obviously, the entire response to the COVID-19 crisis has been by really providing more resources, both to the healthcare system and also to populations at large in terms of income support. And that has been really unprecedented and will be fundamental to facilitate also the recovery. I think we have learned from the financial crisis that, bringing in austerity whilst you are still in the middle of a crisis immediately after is not the way forward. However, I should perhaps challenge you a bit because, and again, it goes back to the issues of, what we learned from the crisis. And quite clearly, the crisis has shown that there are a significant level of underinvestments in the health system. And so the challenge will be both to get rid of some what we highlighted in a previous publication that we had in OECD, some waste in health systems, so spending that does not deliver improved outcomes, even poor safety, that there are significant things in health system can be improved to just get rid of resource utilization that does not deliver into care. But at the same time, it's quite clear that we will also need to invest. And I think that is going to be a challenge because we'll be needing to, in a context in which at some point fiscal pressure will start to kick in, to just say that no, the investment in health needs to be maintained. And I think that's something that's been highlighted by the crisis. We have done a little bit of a back of the envelope calculations actually in the OECD, looking at what are the elements of investments that are needed in health systems. And it starts obviously with the public health, the prevention, the primary care. I mean, on the prevention side, we have said it so many times, only 3% of total health spending is devoted to prevention and public health. But if you look also at primary health care, you see that, only 13% or so, something around those data, 13, 14% of total health spending is devoted to primary health care. And that's clearly quite low. So you need to create some foundational elements of health system that do require investments, and I'll add to that also issues of strengthening the information infrastructure, the data that will allow to manage, to govern the system much better, not just in clinical settings, but also in terms of supporting policy making. The biggest element of spending that we identified comes out to workforce. I mean, we'll come out of this crisis with a workforce that's going to be traumatized at least, but it's quite clear that the bottlenecks have been more in the human resources rather than in the number of beds and the number of ventilators and so forth. And so, if you want to improve the resilience of the health system, there will be a big question that we'll need to address about strengthening and raising the health professionals into the system, starting obviously with the primary care, with the community, with the mental health providers and so forth. So our back of the envelope calculation has been actually that you need to invest something that could be in the magnitude of 1.5% of GDP more into health system to make it more resilient. Now there will be part of it that will be probably a one-off, but part of it that would be need to be recurrent to make sure that you have a system which is ready to face an unexpected shock. And these are clearly discussions that will go on and on and on. And there will be a clear issues and tension when, beyond the immediate moment of the crisis in which we are injecting lots of resources, not just in health, but in fiscal stimulus and in ensuring that we accelerate the recovery once we're out of the moment. At some point, yes, there will be an issue of how do we pay all of that. So this is not to minimize the importance issues of addressing the significant waste in the health system, but it's quite clear that we need to invest and invest differently.
I think also what you're saying about the being prepared for future situations, a big part of the new budget of the EU is basically to try and share some of these preparedness for unexpected events, because we don't need to duplicate everything everywhere. The other thing you mentioned, I think is worthwhile highlighting as well, is that the barriers, the bottlenecks have maybe not always been the number of intensive beds and so on, but rather the staff that has broken down, also because some of them got sick during the pandemic. So I think there's something there when we talk about resilience that we need to consider as well. And finally, if I may say, Francesca, I think what you're talking about in the spending is we should differentiate a little bit more between what is the cost, and a big part of it is that what you proved before is waste, and then investment, and then maybe say what is the value that we get out of investing this money into the healthcare system. So you're nodding, so I suppose you agree on that. Anybody else wants to check in? Marion has nodded a couple of times here, and I think Loukianos wants to come in. Marion?
Yeah, I think it's 2 points maybe. One is around the future of the health workforce. When engaging with a lot of hospital-based staff, all of them, when they talk about innovation, are pointing towards community health as a way to alleviate some of the burden on facility-based care. So task shifting is definitely a big part of the future, but there is still a lot of unclarity, at least from where I sit, as to what are the skills of the future, taking into account digital health. What's the future health workforce look like? And how do we invest accordingly? If we need community health to come more to the forefront, how does that community health workers landscape look like, and what skills do they need to be equipped with? And also what type of tailoring needs to be done in regards to the landscape that the citizens they're serving. So I think there's a big part of that. And then it goes hand in hand with the importance of resilience, I think, of frontline health workers. We've been working a lot on supporting frontline health workers' resilience and psychosocial support specifically during the pandemic. And that's one that is it's ramping up, and I also wonder, what's the future and how can we better support the resilience of frontline health workers and their mental health specifically. So it's half an answer and half more question. I think we have still a lot of questions to answer.
I think we have, Loukianos will answer some of them.
Okay, thank you. Perhaps I can say something which might sound provocative, but I don't think we need to think in a way that this is what we have now for healthcare. We stick to it, and if we try to invest something in one area, we have to really cut spending from other areas. Yes, I totally agree with the fact that there is waste which can be reduced. The OECD has actually made a very good study about this, pinpointing the areas. The transition to value-based care is a very interesting approach that can pay off as well. But we have to take into account that every year there is an increase in demand for healthcare. So even if we invest in primary care more to strengthen it, that doesn't necessarily mean we need to cut down the resources that go to other parts of the care system in hospitals, etc. Let's not forget we have waiting lists and we have backlogs now created because of what COVID has brought to health systems. Many interventions have been postponed. So how do we clear these backlogs? We really have to increase the envelope, the financial envelope for health system. Because the dilemma is if we don't do it now and then another crisis comes in the future, we're going to face again the same financial problems that we're facing now. All the economic downturn right now in terms of GDP is much higher than having an increase in the health budgets on an annual basis. I think the link between health systems and the economy has been underlined so strongly by COVID that I think the message, that the way I understand is, it pays off to invest even more in health systems. Because if we don't do it now, we have not only social consequences, but economic consequences. And I will put a full stop to that. Thank you.
So Simona, thank you very much. Simona, any other questions you have identified?
Yes, maybe one also relating to what Loukianos just mentioned. I would like to ask to the panelists how the current pandemic, what the current pandemic can teach us in terms of preparing for future challenges, but also in how to address current challenges that we are facing. And I would like to link to a question from the audience, from Stefan Joris, who is asking what can we learn from this current pandemic in other fields, in particular the fight against rare diseases, and what the experience with the negotiation of the COVID vaccines can teach us in terms of negotiating for orphan drugs in Europe?
Yes, who would like to address that? I suppose when we're talking about this vaccine process, this also is a question of doing it country by country or doing it at the EU level. Any comments to that? Not really. So we can't learn anything from other diseases, Tinne?
Yeah, I'm sorry. It's a bit broader. It's about what we did we learn from the current pandemic. I think first, if you don't reach out to the communities, then it's of course increasing the problems in the hospitals and intensive care. So you should really invest in reaching the communities. And that's something that we learned, and we knew that already, but we didn't. And so we learned again, and I hope that we can keep this learning and try to make that for sure and invest in the community care. Secondly, health literacy is high on the agenda today, and I think it's quite important, and we should take that further. Not only for the most vulnerable groups, but also for the population. I think that we need to keep that on the agenda, not only with the 5 rules that we need to follow, but much broader. What does it mean in your daily life at individual level and at the population level?
I think in general, also one of the things, Francesca, before I give the floor to you, to remind us what you were saying before, this is also about resilient populations, because this is actually not only helping on the pandemic-like things, but in the general life and death issues that we have. People have proven to be more strong in face of the pandemic if their sort of lifestyle was good and their condition was good. And I suppose this is something that is a general thing. Francesca?
No, just I mean, it's a bit broad and question unclear exactly what you're aiming as an answer, but a couple of observations. First of all, I mean, what we're seeing in this context is a huge innovation that has come across incredibly quickly in terms of coming up in basically 12 months with a brand new vaccine, and actually multiple vaccines. And there are type of vaccines which use a very different novel platform. And so a key question would be also what would be the innovation process into the future. I mean, what we bring back from the pandemic in terms of both the speed at which we have been able to generate innovations, but also the use of some completely new techniques and what's their applications also beyond the current vaccine. I guess there is a broader question, which is also how do we encourage innovations in areas where there is perhaps less innovations. I mean, vaccines were the poor cousin of the innovation process. So were not regarded by pharma necessarily as the most remunerative area. We have seen a huge amount of efforts and very successful efforts. We have seen lots of the public funding that went into accelerating that. So are we seeing new possible public-private partnership models also that are emerging for addressing areas of unmet needs, perhaps? I don't know, there is definitely all sorts of considerations that come into play about the innovation model in health. I mean, what do we want to get, what type of products, how do we leverage a new platform and so forth.
I think in many ways the pandemic has taught us what you were saying here. It provides a lot of innovation. I think somebody a year ago would have said that the vaccines would be ready within 12 months. Most experts would say, no, this is not possible. We can't do that. So actually that has been done. I think the digital sort of contact with primary health care and maybe also the use of it during the health system has improved. But I also think there are things that we haven't learned from really. I don't think, for example, that we have used the test results sufficiently well, coupling it with other data, getting more understanding. And I think, Loukianos, I don't think the member states have actually fully exploited the opportunities of working together in the EU. If I may be honest, I think there's been a little bit of us first before working together. You were provocative before, I was provocative now. Any comments to that?
From my side, I can only say that what COVID has brought upon has emphasized the need for further collaboration on all fronts. Take it from the very beginning, as Francesca was saying, the innovation aspect, research and innovation, to take it all the way to the delivery, to the transfer of patients between countries. And all these are aspects where collaboration can happen. And some of them is happening. And like in everything, there is room for improvement.
Yeah.
Okay.
There was, Simone, if I may, there was just one question that was very open. It was the role of the private sector in all of this. And I mean, are we talking about vaccines here? Are we talking about private and public hospitals? Are we talking about other things? What I have noticed is that the private sector has been, driving the vaccine developments. But I also heard that during the pandemic, we've had public hospitals under strain, while private hospitals were basically empty during the period. So I think there's been a little bit of both sides in this. I'm not sure we have had a full public-private cooperation during this this period, fully satisfactory in all aspects. But this is more a question from the audience to you. Marion, do you have any issues on that or any answers?
Well, if I take it from the foundation's perspective, we talk about systems change with trying to do so in a lot of humility, because obviously it's a term that is thrown around a lot. Yeah. But we see the role of the J&J Foundation as we've shifted our focus from having partnership with various entities to seeing ourselves as a convener of change. So, you know, instead of funding specific outcome, we are starting to place ourselves and try to see how might we bring different actors together to rethink the future we collectively want to see. And some of these conversations typically don't happen because there is a lack and a void in the convening space. Now, the question is always, you know, how neutral can a foundation like ours be in holding that conversation? So we're trying to rely on organizations that have that neutrality to hold that space and to hold those conversations. We've recently worked with the Partnering Initiative in trying to understand what are the learning from our perspective of COVID-19 and how have our partners experienced it, INGOs, the UNICEF of this world and others. And I think a big findings that came through is really that approach of partnering an ecosystem of change takes obviously a lot of time, a lot of compromise and a lot of effort, but we go a lot further by building these ecosystems of change. But we still have a lot to learn in terms of governance. How do we govern change? And you know, how do we bring about the right power dynamics into the mix? So we're trying to use the foundation as a living laboratory on brokering collaboration between governments, specifically in developing countries, big INGOs and NGOs and ourselves, in foreseeing the collective action that we want to all to have, and then ultimately the collective impact that we all want to have. But there is still a lot to be learned. And I use that opportunity to kind of reach out to both the audience and panelists to say, you know, I'm here standing to talk about community health with a lot of humility. A lot of you have a lot more expertise, but we're willing to add value into that space. And we want to hear from various fronts, how do we do so? And, you know, whether we're on the right track or not is something that's very important to us.
Yeah, but I also think that the pandemic had learned or told us that well, you don't waste a good crisis. I mean, you have to pick up the pieces and learn from it. And I think one of the learnings has been you need to use whatever available resources that you have and make them work together. But maybe this is something that we need to develop a bit more, as you were saying. I don't know if anybody else have a comment to that. Otherwise, I'll move towards Simona. Is there any pressuring issues here? Otherwise, I think the time has come to try to conclude.
I think we have addressed the main issues raised through the questions. Maybe if I could add one comment or just a very broad question to our panelists, concluding this interesting conversation. My question would be, how do we make sure that when moving when pushing for this transition, we do not leave anyone behind? And economic models have been mentioned. How can we make sure that those models really incentivize good health while not creating new inequalities?
Yeah, we need quick comments if you have, and I think Tinne has one.
Well, I would insist on co-developing. It's crucial principle within integrated community care. Without developing together with everyone, you will never reach or aim or foster primary care for all.
And Francesca?
In addition to that, I mean, obviously you need to take the root causes upstream. So the root causes of inequalities are not just within the health sector, they lie outside the health sector as well. So you need really that integrated approach, not just between health services, but more broadly, you know, who are the people who are vulnerable, what are the factors of vulnerability, what's the role respectively of health systems, health services, obviously the prevention, as well as other services. It really is big deal to tackle, you know, in a very streamlined way, but starting from the very root causes.
And the causes of inequality is not always just money, it's also culture, it is also social status, it's also education levels and so on and so forth. I mean, it's become a bit more diverse, right? Marianne, Loukianos, any final words here? Or if not,
I can simply add that the principle of many of these reforms and transformations in health systems is to make healthcare more accessible as well. Let's not forget that. Primary care and community care bring care closer to people as an overarching principle. And let's not forget also about the potential of the digital technologies in making care more accessible in certain geographical areas, for instance. And if we put emphasis in health workforce in establishing skills and reinforcing the number of healthcare workers, we can mitigate the problems of the so-called medical deserts. You may have heard the term here as well. So I would say that the intention of the reforms is also to increase access for the broader population. Thank you.
Which means if we go digital, we need to work on digital competences for all as well. Marianne, a very short final remark.
I think resonating with Francesca, we need to broaden the definition of what health is and what is the value that we place in health. It's not just the physical or mental health, it's way beyond that. And I think the health services need to start reflecting that much more broadly.
Well, thank you very much. I think it's been a very interesting 1.5 hours here. And I want to say that the next event that we have addresses within CHESS will address some of the issues that we have been discussing today. The mental health was mentioned as something that needs to be developed. That's something we will deal with. The other thing is the digital development of the health sector. So look forward to the announcements during the spring about these events here. But I had planned a 1.5 hour conclusion here, but there won't be time for that. So let me just say that one of the things that we have clearly agreed on today, and this is experts coming from different areas, has been the need to change emphasis of the health system to create not only a more resilient health system, but also more resilient populations to deal with things in the future. So there's a lot of emphasis now on changing the health system, and all the issues that are surrounded that can make it difficult, but I think it is about time to choose to go that way. And that means integrating systems more. It means integrating from community care out in the social field and further on into the health system. And I think digital technologies can be a big help for that. It means we need to look at our reimbursement systems. We need probably to focus more on value creation. I think we need to try to get more out of the testing that we're doing, the initial diagnosis, make certain that this is transmitted through the health system and that we extract the full value of all the diagnostic information we have. And then I think it is very important that member states understand that they can learn from other countries, and if we identify what works well and if it's well described, it is actually a very good way to reform your own system to try and to adapt some of these best practices. So these are some of the issues that we've been discussing today, and I might not have been completely fair to everybody in my conclusions, but everybody has heard what was going on today, and I think everybody will extract something that can be very useful for the future. So I am indeed very grateful for your time. I was saying to Jan de Masner, even if he left us. Thank you very much to Francesca, to Tinne, to Marion, and to Loukianos. Thank you for your time. It's been enormously valuable for a lot of us, I think, this morning. So let's start working on it and not wait for 10 years, Marion. We go for it now. Yes, we can. Thank you for today.